The chair will now recognize the gentlewoman from California, Ms. Walters, for 5 minutes.
Thank you, Mr. Chairman. California was hit particularly hard this year by the flu season, and my home of Orange County especially suffered with well over twice the number of flu cases compared to last year. Orange County had at least a dozen influenza-related deaths in individuals under the age of 65. Yet we all know that seniors are particularly susceptible to the flu. The CDC states that at least 75% of flu-related deaths occur in people 65 and older. My district is home to a large retirement population, so I'm especially concerned about the health of this group during flu season. While the overall flu vaccine effectiveness rate for this year is 36%, the effectiveness rate can vary depending on age group. For instance, last year, the overall effectiveness rate was 40%, and the effectiveness rate for seniors was only 25%. One would suspect the vaccine effectiveness rate is lower for vulnerable populations like seniors, but I noticed that the 2016-2017 vaccine effectiveness rate was much more effective for children, another vulnerable population. Some of my colleagues have asked what accounts for the variability in flu vaccine effectiveness among age groups. What can be done to improve vaccine effectiveness for seniors?
I can begin. There have been efforts to develop different influenza vaccine products, particularly for seniors and others with weaker immune systems. One such approach is a high-dose product that's been licensed. Another approach is adjuvanted. A key strategy that we have at CDC is to make sure that patients and clinicians know that people at high risk for complications, including seniors, get promptly treated with antivirals if they do get sick. But the immune system does age, and we think that the frailer elderly have a poor response to many vaccines, including flu.
Whenever we have a situation, for example, when we are making a vaccine for a possible pandemic, we always test it not only in healthy adults, but we also test it in the elderly to make sure that the dose and the regimen that we have gives a comparable response that a younger person would have. So that's part of the testing. And as Dr. Schuckert said, the two major areas are the higher dose, which is recommended for seniors. It's a much higher dose than the dose that you give to a healthy young person, as well as using adjuvants, which is a product that's not a vaccine, but it boosts the response to the vaccine.
If I could add too, I mean, this is a lesson from pandemic influenza vaccine development that we can transition to seasonal influenza vaccine development. We know in a pandemic vaccine, we have to have higher doses of antigen, and we have to have adjuvants in those vaccines to make them immunogenic and effective across all age groups. I recently, in the last 2 weeks, visited the senior leadership of each of the licensed influenza vaccine manufacturers for the United States and talked to them about this challenge, about what their thoughts and strategies on how we can improve the effectiveness of our existing vaccines while we wait for the universal flu vaccine. Each of them is poised and strategic in thinking about ways to add the adjuvant and increase the dose of their vaccine. They're all partnered and interested in utilizing cell-based and recombinant-based vaccines as well to try to improve the effectiveness over the egg-based vaccines.
I'll just comment very briefly, Congresswoman, that we're actively looking at data as to the relative effectiveness of the vaccine with the MF59 adjuvant and the high-dose vaccine in elderly patients relative to the normal vaccine, the regular dose vaccine with the 15 micrograms of antigen. And I think if we do observe differences between the high-dose vaccine, the efficacy of the high-dose vaccine, or the vaccine with the adjuvant and relative to the regular seasonal flu vaccine, it could offer some clues as to why the vaccine overall was less effective against H3N2. We will have that data available hopefully shortly. We're working very closely with CMS to derive those results, and we're going to make it available as soon as we have it.
Okay. And Dr. Schuckert, in 2009, the FDA approved a high-dose version of the flu vaccine for elderly individuals. There is a study that indicates the high-dose vaccine was 24.2% more effective in preventing the flu in adults aged 65 and older as compared to the standard dose vaccine. Can you elaborate on whether the high-dose vaccine would significantly reduce flu-related deaths among seniors?
Even a 20 some percent superior response is still not, 100% because of the weaker immune response that seniors get. We have the market of the higher dose product has been increasing since it was became available. CDC doesn't recommend a preference for the high dose over the regular dose vaccine. One of the things we found is that the vaccine that they have at the doctor's office or the pharmacy is the one that you should get because there may not be the other product if you're looking for it. But I think the additional studies that that FDA is doing with CMS and we've done with CMS in the past has helped us build this evidence base of what's the best way to protect seniors.
Okay, thank you, and I'm out of time. Thank you.